To say welcome to all. For this particular webinar, we have both English and Spanish captions available. If you're joining us live on Zoom, please check the chat box as we're adding the instructions right now. And if you're watching the recording, you will find it in the video description, instructions on how to activate the subtitles. I want to say a big thank you to our sponsors, Amylyx and Biogen. We couldn't do what we do at the Alliance without the support of our industry partners. For those of you who don't know me, I'm Kathy Cummings, Executive Director of the International Alliance of ALS-MND Associations, and I'm joined today by a very special panel to start our webinar series that's focused on care. This particular webinar will address from different viewpoints what you need to know at diagnosis. This webinar series came about after coming across a tweet from Chris Snow, which you should now see on your screen. Chris Snow is a hockey coach and manager living with ALS-MND in Canada. And in his tweet, he says that a national media member called him and his sibling had ALS. And he gave him his checklist: what to do at diagnosis, demand genetic testing, exhaust clinical trial options, have a high calorie diet, high rep, low weight exercises, and hands grip aid. So this was his checklist of what needed to be done at diagnosis. And that really spurred the conversation that we're going to have today with experts at a global level of how they work at diagnosis as well. We have an incredible panel, which will provide you with their input of what you need to know at diagnosis. Leslie Ryan, our moderator, is the Senior Director of Education and Professional Competencies at the ALS Association in the United States. Joining her are Dr. Ammar Al-Chalabi, who's a neurologist from the UK, and Bugyeong Son, an ALS-MND nurse coordinator from the Republic of Korea. We will also hear from Bernice You, who unfortunately can't join us live, but she'll be sharing her experience and viewpoint as a person living with ALS-MND. I now turn the floor over to Leslie.
Thank you so much, Kathy. And hello to everyone. Thank you for joining us, whether you're joining us live or watching this recorded at a later date. I do want to let you know that if you're watching this live, you have the opportunity to ask questions throughout the presentation. Simply enter them in the chat box at the bottom of your screen or the Q&A, and we will have time for questions at the end of the presentation. I would now like to invite my panelists to introduce themselves. Ammar, would you like to begin?
Thank you very much, Leslie. I'm Ammar Al-Chalabi. I'm a neurologist from King's College London in the UK. Thank
you. And Bugyeong?
Hello, I'm Bugyeong Son from Seoul, Korea. I am ALS-MND nurse coordinator in Hanyang University and a director of international cooperation and Korean ALS Association. Thank you for having me.
Thank you both for being here. I'm looking forward to the conversation today. So to get started with the conversation, I would like to introduce you to Bernice You. She is a person living with ALS-MND, and she's going to share with us about what her experience was like when she was first diagnosed.
I'm Bernice You, a PALS person with ALS. I live in the United States with my husband and 3 kids. I'm glad to join the webinar today to share my experience and learning from a PALS perspective. I was diagnosed with ALS-MND in March 2021 at the Center of Excellence ALS Clinic. I'm very fortunate to be under their care as they take a multidisciplinary program approach, and I found it tremendously helpful. They provide care across different areas that I'll possibly need support with, and it takes away the burden from patients so I don't have to navigate the complex medical system. And I'd advise all pals to get access to such a clinic if possible. And looking back at my journey so far, I have so much learnings, and some I wish I knew from the start, and I'd like to share them with you. And my top 5 learnings are energy management, breathing support, clinical trials, get equipment early, and mental health. So first, energy management. Fatigue was a big issue for me from the start. I felt tired all the time. If I did a work meeting, I couldn't go out with friends for coffee afterwards. I felt like I could only do one thing a day. And what has helped me a lot tremendously is to boost my nutrition intake and to plan my day ahead. Only allow certain things in my schedule, don't overload it. And most importantly is to building recovery time. I find a combination of those help me to still be able to enjoy activities with my family and friends, even with my limited energy reserve. And second, breathing support. This one is a big learning for me. So my breathing was impacted from the start. And since diagnosis, I've been using a non-invasive ventilator at night during sleep. And I was fortunate that I got care with a great pulmonologist. But as days go on, I got more fatigue and I have headaches. And even sometimes I had confusion when my friends' families were talking to me and I couldn't comprehend what they were saying. And I felt I was losing my mind. So I mentioned this to my pulmonologist, and he asked to see me the next day, and he tested my carbon dioxide. And as he suspected, I had carbon dioxide retention. And afterwards, I started to use my ventilator also during the day. So I advise all pals to get connected with a pulmonologist to get breathing support and care, and watch out for warning signs. Take care of your breathing and just be safe. And my third learning is clinical trials. And this one I really regretted that I didn't get educated myself early on and didn't push for it. And now I couldn't get into any clinical trials because of my low breathing function. And as there's been so much progress and advancement in research, I think there are many hopeful options. So if this is the direction you'd like to take, please tackle this early on. And the fourth one is to get equipment early. You know, I used to think equipment is something I'll only use when I absolutely cannot do something. So for example, if I cannot walk at all one day, that's when I would consider a power wheelchair. And I think it's really my mentality getting in the way. Instead of seeing the equipment as a tool to help me, I see it as a symbol of failure, which is totally not the right mindset. Unfortunately, I have a great care team, and my neurologist suggested last summer that I started to use a power wheelchair. And I'm so glad that I listened to his advice. Though I can still walk from room to room at home, I have to use a power wheelchair when I go out because of my leg weakness and my compromised breathing function. But I'm so glad I got my chair. I love it. It gives me freedom. It saves me energy. And now I can do activities with my families and friends and have fun together. So get equipment early. They are there to help you. And the last one is mental health. This one is the hardest for me so far, and to be honest, still hard at times. I think my mistake is that from the start, I've been so focused on the physical aspect of this disease, and I neglected on the mental health, on the toll that it can take on me. And I struggled a lot in the early days, and I went through a huge transition of my self-identity. From someone independent with a successful career to someone not really working and needed help from time to time, not so independent. And what has helped me tremendously is my faith, my family, and friends. So I would advise all pals to do whatever works for you to take care of your mental health. Whether it's therapy, religion, your family, friends, or even to just pick up a new hobby. There are so many joys in life, even small things can count. So mental health, I think our mental strength is what that's going to carry us through no matter what happens. And to conclude, I want to say, though we may live in different shape and form, there can still be meaning, purpose, and much joy in life. And with the advancement in research and technology innovations, I believe there's much hope. I hope my sharing is helpful. Thank you for having me.
Thank you, Bernice, for sharing those beautiful insights and your experience with us. I think you did a really wonderful job of articulating so many of the things that come along with an ALS diagnosis that maybe we don't think about initially. And I love that you included mental health as part of what you see as one of the things to really focus on, because there is more to this diagnosis than just the physical aspects of what people need to focus on when they're first diagnosed. There's a lot to come to terms with. This is a great place to start our conversation. Ammar, I'd like to start with you. When someone is diagnosed, giving an ALS diagnosis or an MND diagnosis has got to be difficult. That's, I imagine, not an easy conversation. What are some of the things that are important to you to include with those initial diagnosis appointments when you're meeting with people diagnosed with ALS and MND?
Well, the first thing to say is, of course, it's very difficult, but it's never as difficult for us as it is for the person receiving the information. It's also different in different clinic types. If someone's being seen by a general neurologist, they will be given the diagnosis in a different way from if they're seeing an ALS specialist. So I'm going to be talking, of course, from an ALS specialist point of view, just to make that clear. I use two principles which were taught to me by Professor Nigel Lee, who is my mentor. And that was, the first one is never destroy hope. And the second one is make sure that no one feels abandoned. And I think those two things have driven certainly our clinical practice where I work. The first thing I always do is check to know how much the patient understands already. Because we're in the age of Google, it's quite easy for people to type in something like fasciculation or some word like that. And so many people come to us knowing already the diagnosis might be ALS or having a strong inclination that might be the diagnosis. So it's not, although there is, of course, still a dramatic shock when someone's given the diagnosis, it's not as big a shock as it used to be when I first started back in the 1990s, giving the diagnosis of ALS, because people have thought perhaps it is ALS when they come to us. And the other thing to say is we give a lot of information in that first visit, and it's at a time when someone's just been given the diagnosis. Actually, most of it is not really taken in or retained. It's still important to do that, but also to do it in a calm, supportive environment where people have the chance to be listened to as well. So a lot of what we do is stay in silence. The carers and family are always with the patient, so that's why I always make sure that I do give the information. I also give it written by hand in the clinic, and I also give them a copy of my letter when I write to their doctor, and that goes through everything that we've discussed in the clinic, so they have it written as well. So the first thing I do is I go through the story, the examination, the investigation findings, and discuss those with the person. And then I usually explain what motor neurone disease, or ALS, it's motor neurone disease for us in the UK, what ALS is, anatomically, what's going on, why is this person experiencing these symptoms. And I usually draw a diagram, and I talk about the motor system, the ALS motor system, the human motor system, because actually our motor system is a bit like a Ferrari. It's a very highly tuned, amazing motor system. It's the most advanced motor system in the animal kingdom. But like a Ferrari, if it goes wrong, it's very difficult to fix. It's also high maintenance. Whereas if we had something more generic, like a Ford Escort or something like that, some basic car, it's less likely to go wrong. And it's easier to fix when it goes wrong. And that's more like a kind of mouse's nervous system. So, and that's probably why humans, we have a double-edged sword in having such an amazing motor system. So I go through that, and then of course I go through what we can do and go through the detail of that.
I like that you present things in such a diverse manner, verbally and written, as well as doing the diagrams, because as humans, we do need to figure out, everybody absorbs information differently and learns and hears things differently. And that moment of diagnosis, whether someone is expecting it or not, can be so overwhelming. To your point, most of it isn't even absorbed initially. So that's great. Bugyeong, what has your experience been when you first meet with people diagnosed with ALS-MND in your clinic?
I'm a nurse, and in Korea, mostly doctor and a neurologist gives the final diagnosis to the patient. So fortunately, I am not the one who breaks the diagnosis, but I usually take questions after their meeting with the doctor. And there are some questions that patients cannot or missed to ask the doctor. So I try to give them more explanation and in more detail and practical way. And also try to give enough information as much as possible, and also address them. There are questions that cannot be answered, and it's important that the patient and the family is now involved in a big ALS group, and we are in the middle of the history to figure out ALS together. So it's important to collaborate with patients and family and the researcher and the doctors and nurses in the hospital as well. So try to build a good relationship and try to visit regularly with us and give help with each other. So that's what we do on the first day of diagnosis.
I love that I'm hearing from both of you that relationship building and that giving help and support and comfort and a trusted place for people to return to ask their questions and continue to get care, because I think that is so incredibly important when faced with a diagnosis such as this. That leads me right into our multidisciplinary care teams. We know that multidisciplinary care is very important in living with ALS MND. Ammar, how do you introduce a multidisciplinary team to people once they're diagnosed and get them engaged from the beginning with a team of professionals that they may not think they need right away?
So we have two components to the multidisciplinary team. One is the specialist team actually in the hospital, in the specialist center, and they have a lot of experience with ALS, but they're not local to the patient. And so the other team that has to be involved is the community team that is available to go out to people's homes or for them to visit much more locally. So we actually have a care coordinator who coordinates both of those teams. That's their job. The team itself, we don't introduce them on the very first visit when they've just been given the diagnosis, because that visit is usually at least an hour and a half long, sometimes much longer, because there's a lot to get through. And it's very tiring for the person who may have traveled a long way to come to a specialist center as well, and then have a long journey home, having been given distressing news. So what we usually do is we bring back people within the next 4 weeks, especially to see the multidisciplinary team. And that gives people time to reflect, to absorb, to speak to family and friends, and have other questions that they may want addressed as well, which they can then bring back at that appointment. That's also the appointment where we discuss research in much more detail, although we do discuss that in the first visit. So the team, they come back after a month, roughly, usually a bit earlier, and they'll meet. There's 3 particular components of the team that are very important, I think. So we have a palliative care specialist, and palliative care is usually associated with end-of-life care, but that's not why we have palliative care in our service. It's actually, I mean, it is, of course, towards the end, we will need that. But the real reason to have palliative care actually involved early is because they're experts in understanding the whole person and the impact of the condition on that person. And they're experts in symptom control, and they can provide counseling. And I'm a neurologist. I see people as brains, nerves, and muscles. The palliative care specialist is trained to see them as a person with their faiths, their beliefs, their family, their career, their life, and they can understand how the disease impacts them in that way. So they're a much more important person than I am in terms of particularly protecting the person's mental health. We also have the respiratory team, the pulmonologist, as Bernice discussed, and we have then the rest of the multidisciplinary team, the therapists. We have a big group of therapists. So we have physical therapy, occupational therapy, speech and language therapy, dietetics. We have a clinical nurse specialist, and we also have the clinical care coordinator that was mentioned. We, if necessary, bring in cognitive assessment. We also have a wheelchair therapist, and we have a voice banking specialist. So those are all the people within the team. There are other members as well who come and go, but those are the main members of the team. So they're introduced after the first month.
Great. Bugyeong, how do you work with the patient and their family as they meet with the multidisciplinary team at your clinic?
I was quite surprised at Dr. Ammar's clinic and how systemized they are and well-functioned in the patient perspective, because I think it's important to connect the ALS specialist and the local clinic, and that's what we need. We are working on right now in Korea and in our hospital. So we have a multidisciplinary team like Dr. Ammar's hospital, but it's a little different. We have nutritionists, physiotherapists, respiratory specialists, occupation therapists, and home visit nurses, and we have social worker as well, and neurologist nurses, nurse coordinators like me, and we have base group settings for multidisciplinary team, but like your clinic, we don't introduce them to the patient in their early diagnosis, and sometimes it seems very tiring to meet new people. Even though they are helping them, it seems like a burden to meet new people and introducing themselves and getting a new relationship in the hospital. So we try to do them one by one, and depending on their symptom, that we usually try to connect with the physiotherapist first, usually on their diagnosis. And when they are admitted to the hospital, and if we enter their height and weight, BMI is automatically calculated, and if their BMI is too low or too high, the system automatically connects it to the nutritionist, and then the nutritionist see their blood test results and consulting them with their regular diet. And we also connect them with physiotherapists. That's very popular in our early diagnosis, and try to connect the therapy in their local area. And also we have clinical trial coordinators, and they are usually introduced in the early on of their diagnosis. I'm sorry. So I hope our patients enjoys meeting with new people, and sometimes it needs waiting, because we are waiting in line for meeting new people, and sometimes the help may not feel very helpful as they expected. But I hope it's helpful in the long run, and our team is here to help. So I hope we can gradually build a good relationship during the journey.
I think that, again, that theme of relationship building is so important. And I know in my experience working with families here in the US, we really encourage them to meet with their multidisciplinary team members from the beginning. Again, not right at diagnosis, like you've both mentioned, but early on, before they're needed, so that the specialist can really help to maybe predict when some challenges or changes may be coming and stay a step ahead. I think that all of us know that staying a step ahead with a diagnosis like ALS-MND is one of the most important things that we can do. And being able to prepare and plan for equipment or for changes in breathing or changes in nutrition status and being able to safely swallow, things like that are really important. And so having those specialists there, building that relationship early on, who can keep an eye on the patient as they continue to progress, is very important. And that way the burden isn't on the person who's diagnosed or their family and friends to have to know when it is time to call the pulmonologist or when it is time to get a feeding tube or any of the other decisions they need to make. So you both mentioned specific areas of the multidisciplinary team. I'd like to talk a little bit about nutrition, because this was one of the things Chris mentioned in his tweet that Kathy read at the beginning of this webinar. Ammar, why is nutrition important early on in diagnosis?
It's important, actually, because Bernice, as Bernice said about energy, it also, there's soft evidence that having more weight on board than perhaps you should is good, that it slows the disease down. There's no definite causal link yet in the research, but there is a lot of soft evidence that having more weight on or putting on weight might be beneficial. So we try and encourage that as far as possible. And in any case, we need to do that because people with ALS reduce the amount of calorie intake they have anyway for multiple reasons. Low mood, which we've heard is quite common, and of course it would be. Being less active, if you have any kind of disability, you're less active than you were, and exercise usually encourages appetite. It's more difficult to handle food and cutlery, and so it might be more of a chore to eat, and it just takes longer, by which time the food has gone cold or doesn't taste so good or look so good. It's more difficult to swallow. That also affects how much you want to eat. So all of those things affect how much you want to eat, but as well, we know that there's actually a metabolic change in people with ALS, that the mitochondria, which are the little batteries in the cells, they're working less efficiently, so that you need more calories just to stay where you were in the first place. So actually increasing the number of calories you're taking in is a good idea for that reason. Achieving that is another matter, but that's what we try and aim for. And so I always tell people that they shouldn't care too much about eating healthily. They should just eat basically what they want and what they enjoy. Don't mind if you put on some extra weight, but also realize that it is to some extent a losing battle, and that weight loss may well occur regardless. And part of that weight loss is muscle loss, but actually a significant part of that weight loss is something we don't understand. It is just weight loss that's not from muscles. It's not because the muscles become thin. The person actually loses fat and loses weight for other reasons. A bit like can happen in cancer. People just become thin. It's called cachexia is the medical term for it. And we don't really understand why that happens. So eating a lot, good nutritional support is vital.
Bugyeong, what about you? Do you have any tips around nutrition early on in diagnosis?
Dr. Ammar mentioned it really well. I want to add that usually when we tell our patients that a high-calorie diet is important, Asians usually tend to eat more carbohydrates. So we highlight that you need a balanced diet, especially you need more meat, fish, and good fat. So I want to add, especially for Korean and Asian diet, and also patients starting with their bulbar symptoms, especially dysphagia, we recommend them not to be too afraid of having a PEG tube, because without their symptom, they look completely healthy, and they feel like Bernice said, some patients think if they have a PEG tube inserted, they feel like they are becoming a patient suddenly, or they become a failure. But but it is not. So we think getting a PEG tube is safer, and it should be done in a proper timing, and patients will feel much better, much safer, and won't be suffered from frequent choking when they eat. So considering a PEG tube at the right moment is important, and also it's covered with your shirt, so it won't be seen by others. So considering PEG tube in a early, in a good timing is also important.
That's great information, and the education around what a PEG tube will look like and what it means to live with that, I think is very important, because many times in my experience with our clinic team and meeting with patients who are newly diagnosed, the first thing they say is, I don't want any of that. I don't want any tubes. And then spending that time to educate from the beginning around the importance of nutrition, and then the importance of safe nutrition is something that is so valuable.
Leslie, can I just add there? There is a resource which we use, which is called MyTube. I can give you the link to add with this webinar later. But the MyTube website has a number of videos on it, and it leads people through, it's an educational resource. So people can see, what does having a tube of different types entail? What does not having a tube entail? And what is the impact on the person? What's the impact on family? What happens before the tube is given? What happens when the tube is being put in? What happens afterwards? So it's a very useful resource. It's all videos, and it's all people who've gone through the process.
Oh, that's a wonderful resource. Yes, we will definitely share that. Thank you. So equally as important, as Bernice mentioned, is respiratory care. And I think many times when someone first learns about ALS MND, they're thinking this is a muscle disease, right? Or a nerve disease, and they're not necessarily thinking I need to see a pulmonologist. And so, Ammar, for people who are newly diagnosed or just starting to learn about ALS MND, why is respiratory care and a respiratory assessment early on so important?
Well, someone breathes mainly with their diaphragm. You do, of course, use your chest a bit, but most of the breathing you're doing is with your diaphragm, and the diaphragm is a muscle. And actually the nerves for that muscle come from the neck and then come down into your diaphragm below your chest. So because it's a muscle that is under some voluntary control, because we can, of course, hold our breath or regulate our breathing to speak, it's therefore vulnerable in the same way as any other muscle that's for voluntary control in ALS. So it can become affected, and when it's affected, it doesn't work so well. Now, initially, if your diaphragm isn't working well, what you'll experience is perhaps increased breathlessness walking up a hill, or some kind of when you're doing strenuous exercise. But it can also affect people when they lie flat. And the reason for that is when you lie flat, your gut is leaning against your diaphragm, whereas when you're standing up, gravity pulls your gut down, so your diaphragm can just move up and down with no problem. When you're lying flat, your diaphragm has to push your gut out of the way to take a breath in, because the way it works is it pushes down, which increases the volume of your chest, and that sucks air in. And then when it relaxes, the elasticity of your lungs just collapses them down and your air comes out. So it's the process of taking air in that's the issue. So if you're lying flat, that's more difficult. So at night, for example, because your diaphragm is splinted by all your gut contents. So that's when people may notice it as well. And that's why when we use respiratory support, like non-invasive ventilation, it's more usually given at night initially, even if it's only for a short while, just because that's the time when people may first notice symptoms. And before NIV existed, before we knew it was useful, which is actually when I started in the ALS field, people didn't use NIV. It was a remarkable idea when someone first thought of it, which seems a bit crazy now. People used to have to sleep sitting up, and then we would give drugs that made them not feel so breathless and not panicky. That was the way that people were treated. So the idea of non-invasive ventilation was radical at the time, back in the 1990s. It's not very long ago, in fact.
Bugyeong, in your experience, what are some of the common questions around respiratory care for people who are newly diagnosed?
So sometimes patient does not know that they have respiratory symptoms. They think that time for NIV is when they feel breathlessness. But usually patient who complains about breathlessness when lying flat, or just like Dr. Ammar said, like they feel not comfortable lying down flat, but instead they prefer to lie on lateral, like on their side, or they have morning headache, or they have bad dream frequently. That may be the sign of their respiratory problem. So in that case, it would be better to tell your doctor or nurse about the symptom, because that may indicate some signs as well. And just like PAC-tube, NIV, it also looks scary on the first place. And patients usually think that having an NIV or a respiratory support machine makes them getting closer to death. So there are some fear of experiencing respiratory symptoms by themselves, and I totally understand. But NIV is quite simple, it's easy to use, and it's not only for ALS patients, but a patient with sleep apnea uses CPAP. It just works just like an IV, and it's widely used. So and the procedure is widely performed. So it's not only for the terminal stage patients, but we will monitor it's important to monitor your respiratory symptoms from early on.
Thank you both. I think that also Bernice mentioned energy conservation being something that is so important. And even prior to NIV, doing some things throughout the day, sitting down while you're getting ready in the morning, or sitting down while you're taking a shower, or propping up the head of the bed with some pillows, some simple things that people can do as well to conserve energy and make the work of breathing a little bit easier early on is so important. And then again, meeting that pulmonologist and the respiratory therapist, and understanding respiratory testing and getting a good baseline at diagnosis is so important. So it's definitely a key piece of the multidisciplinary team.
There is also another resource, a bit like the MyTube resource, which is MyNIV, which again, I can send you the link for that. And actually, the other reason it's important to consider, I mean, everyone should have their breathing tested routinely every 3 months minimum anyway. That's the kind of best practice. But the other reason is because some of the symptoms can just be things like loss of appetite or loss of concentration, which aren't necessarily something someone would associate with having breathing impairment. And the reason for that is actually the reason we breathe isn't so much to bring in oxygen. It's actually more to get rid of carbon dioxide. That's the primary driver of breathing. And so if you're not ventilating as much as you normally would, carbon dioxide will build up, and that can affect thinking.
Great point. Thank you. So as we know, the person diagnosed with ALS-MND is not the only one going through this journey. Their family, friends, caregivers are all along in this experience as well. And this is not easy for them either. And so, Ammar, when you have people initially diagnosed who may come alone to their appointments, not bring their spouse or partner or primary caregiver, how do you encourage them to engage their family and have them come, or do you encourage them to bring their family along to appointments with the multidisciplinary team or with you, or how do you encourage them getting involved?
Yeah, so not everybody has family, of course, to bring along. So occasionally people really are completely on their own, particularly in the age group that's more prone to ALS. But yes, we always encourage people to bring family friends. Actually, we do that with the appointment letter. When it first goes out, we encourage people to bring their family and anybody else who may be relevant in their life. And we do that as well at the first appointment, and we encourage them when they come to the palliative care team, because of course that's important at that point. But not everybody wants their family involved right at the beginning, and particularly if they've got young children, for example, they may not want them to know, or if that child is going through an exam period or something like that, there may be reasons why they want to keep the diagnosis hidden for some time. And that brings up two problems. So one of them is the conspiracy of silence, where the family member who isn't told actually does know what's going on, but doesn't want to hurt the feelings of the person who does know, and vice versa. And so nobody says anything and nobody talks about it. So that's a very important reason to get everybody in the same room so everyone knows what everybody knows. So we try and avoid the conspiracy of silence if possible. But if someone doesn't want their family to know, we have to, of course, respect that. There are tools available that can help people know how to let their family know, particularly if it's children. For example, the MND Association in the UK has a booklet called Motor Neurone Disease, A Family Affair. And I'm sure that the Association has something similar. So it's very important to let family know when the time is right. But of course, that information and that control resides with the person living with ALS.
Absolutely. Bugyeong, how do you approach the importance of having family members involved?
I truly appreciate that Dr. Ammar pointed very beautifully that I think it's a very sensitive issue that, like some patients, they don't want their family member to give a caregiver job that nobody expected, or the family caregiver, they don't want to accept it or take more time to get that they are a caregiver, and the patient will lose their motors. But if I have to choose between the two, I personally think visiting the clinic with the family or friends and learn about the disease together is more helpful in the long run. And I think the disease is fast progressing disease, but at the same time, it's not that fast that we it should take time together to see the progression, see the symptom at the right moment, and provide symptom management, provide right care at that moment. So if there are some family caregiver who leave the patient alone and respect the patient's own will and patient's decision. So the patient comes to the clinic by himself for like a couple months, but at the, all of a sudden the patient has a breathing problem and almost paralyzed, and the caregiver does not accept the role and has a really hard time mentally and physically to take care of the patient. So I think it's a very bad case, but I think that talking about their diagnosis, talking about their symptom, even if they are not coming to the clinic together, going to the journey together and find your own balance and your family dynamic is very important. And like Dr. Ammar said, there are some young parents, they don't want their kids to know about their diagnosis. In Korea, or maybe in Asian culture, there are some kids who get their parents' diagnosis first and want their parents not know about their own diagnosis because they're old, and the kids worried that the patient may lose their hope of their remaining life. So in that case as well, conspiracy is important, and we think that the patient has to know the diagnosis, and the family is being in the clinic and being in their life together, supporting, is more important than not to tell their family member.
Thank you for sharing your experience. It's definitely a challenging time as everyone involved starts to accept the diagnosis and accept it in different ways. And I think it is important that family members understand that the multidisciplinary care team is there to share information and support them as well, as appropriate for their individual situation. So moving on a little bit, the Alliance did a survey last year, and it touched on access to genetic counseling and testing. The results showed that these are not accessible in many countries or jurisdictions and do not happen close to diagnosis. Ammar, can you explain to us the importance of genetic testing early on in diagnosis and why it should be done alongside genetic counseling?
Yes, so there is a genetic component to ALS that is detectable in about 15% of people. And they don't necessarily have a family history. But of course, most people with a family history, if you have a family history, you're more likely to have a positive genetic test when tested. But even then you may not, because we don't know all the genes that can cause ALS. But if you don't have a family history, you may still have a gene that would normally be associated with a family history. And that may be surprising to people, but the reason is having a gene isn't enough on its own. Having a gene variation that causes ALS isn't enough on its own to definitely cause ALS. And I think we've discussed this in other places online, so you can see that there if you want. But the basic issue is, unless we test people, we won't know if they're carrying that gene variant. The genes don't change the type of ALS. Having someone with ALS, you can't tell by looking at them, do you have a genetic cause of your ALS or not? And so genetic testing is important for that reason, because if you know the genetic basis of someone's ALS, if they have a genetic cause, then potentially you could either enroll them into a gene therapy trial, and there's lots of those going on at the moment. 2 of them have reported recently. But regardless of that, it has implications for other family members, and therefore it's important to know in some situations. Now, just getting that information, just doing a blood test, sending it off and saying, oh yes, you carry a gene mutation for ALS. You can't do that. There are massive implications to being told you have a positive test. Actually, there are also massive implications to being told you have a negative test. And what sometimes happens, fairly frequently in fact, is something in between where we have a variant of uncertain significance, which means there's a genetic change in a gene that's known to be relevant for ALS, but we can't interpret that change because it's never been seen in anybody else, or it's only been seen in a few people, so we don't know if it's coincidental or actually relevant to that person's ALS. So genetic testing must be done on the basis of counseling so that you can explain the implications both to the person with ALS and to their family of a positive test, a negative test, and one of these uncertain tests. And that counseling can take about an hour, 2 hours, depends on the situation. And so it's not something, again, you can easily do at that first visit. Because of gene therapies coming online, because of the different trials, it's going to become a more and more important and crucial thing to do and to offer for everybody. Not everybody will want genetic testing after counseling. It has implications for life insurance and things like that as well. So it's something that definitely needs to be thought about in great detail before the person agrees to it. But if they agree, they have to know what that means, what the outcome means.
Absolutely. And is there a difference in getting genetic testing from a clinical standpoint, just to know, as you're describing, versus being involved in a clinical trial and doing genetic testing for research?
So if you're tested for research, you may not get the result. It depends on the exact way the ethical approval was given for that research program. For us, we usually have an ethics approval that means we cannot give the person their genetic result for research. It's anonymized. We don't know, we don't link the sample with the person. It's completely anonymized. If the person wants genetic testing for diagnosis, they have to go through counseling, and it's sent to an accredited laboratory that does it and then gives the result back in a specific way. So the two things are separated. Genetic testing for diagnosis and genetic testing for research are separate in the UK. And I think that's true in most countries, but not all.
Bugyeong, what is the current situation with genetic counseling and testing in Korea?
Just like Ammar mentioned, we have genetic testing for diagnosis and genetic testing for research. Usually of diagnosis, we include SOD1. And SOD1 testing I think it's quite widely prescribed in Korea, especially if the patients are young or patients have family history of ALS or patients with frontotemporal dementia. They are usually recommended to have their genes tested, and I think it's widely accepted. But as Dr. Ammar mentioned, testing is the patient's own decision. So more important thing is having a genetic counseling beforehand and afterward as well. Especially a genetic counselor cannot answer all your questions or cannot make a decision for you, but you can make your own decision based on the scientific information that genetic counselor can advise. So genetic counseling is very important, and which I think Korea should work on, because the National Health Insurance does not cover genetic counseling. It's not specified specialist field. So that's what we have to work on in the future. And at the same time, accessing to genetic testing is also important part. That SOD1 testing is quite common, quite popular, and it's easily accessible. But other genetic testing, including FOS, Ataxin-1, NEC1, etc., they are expensive, and the patient have to see specialist who knows about these genes well and can prescribe the test and link to the lab and interpret as well. And also we do whole exome sequencing in a research field, and it's not accessible in all clinic. So some specialized clinic do it for a research purpose with their own research fund. So it's not well accessible. So yeah, I want to highlight that genetic counseling is important, and you should ask for it, and giving more access nationwide or worldwide to genetic testing is what we should work on in the future.
I agree. The ALS Association has created a document that is shared in the chat that is how to talk with your doctor about genetic testing, and I think it can be very important for people who are newly diagnosed. Ammar, how important is it for people to get genetic testing early on in their diagnosis, or does it matter when they get the testing done?
At the moment, because there isn't a treatment based on genetics that has been approved, it's not quite so critical to get it done very early on. That may well change in the future, and particularly with trials if they need to recruit people early in the disease or even before they develop ALS. So at the moment, it's not absolutely critical, but I think that will change.
That's exciting news, because that means the potential for therapies are on the horizon. I think we all feel that across the globe. So I'm going to ask both of you the same question to wrap things up before we go to the Q&A. What are the most common questions you get asked at the time of diagnosis? And Bugyeong, I'll start with you. What do you hear from people when they come in and they've gotten a diagnosis and they're overwhelmed or confused or scared? What are some of the common things you hear?
Okay. There are so many. Even though patients Googled ALS first, they ask, is my progression fast compared to average, or is my children likely to be diagnosed like ALS, or can I get some financial support from the government, or can I join the clinical trial, etc., something like that. And we have a patient guidebook for patients who just diagnosed. So it addresses these points clearly, and it's not very long, so that the patients are not overwhelmed by the information. And at the same time, I will also want to point out that the International Alliance webpage has a really great section that tackles questions that patients are interested, and it's very well categorized, so patients will not be drowned in the lots of information. And also it has links outside the Alliance webpage so that patients can research deeper if they're interested in a specific field.
Great. Ammar, what are some of the questions that you hear most frequently?
So I agree with Bugyeong that those are the same questions we get. The main ones we get are, why have I got ALS is a very common question. What's caused it for me? And then people come up with possible explanations from their own experience. I broke my leg, I injured myself, or I caught some kind of infection, that kind of thing. People want to know if it's infectious sometimes. People often ask about stem cells. Can you treat this with stem cells? They want to know about alternative therapies. They want to know how long they've got to live quite often, and they want to know if it'll affect family members. So we do discuss all of those things. And then, of course, a very common question, actually, which is something we haven't talked about at all here, is riluzole and whether they should take riluzole. And I strongly advocate for riluzole. Most people say to me, oh, it only adds 3 months of life, it's not worth taking. But actually, that's a misinterpretation of the initial clinical trial data. If you look at the initial clinical trial, it showed a 38% improvement in survival at 12 months, because that was all the data the trial had. And so that was 3 or 4 months in the trial. But the method they used in the trial, which is called a proportional hazards method, the statistics of that assume that the effect continues. So it's 38% at 2 years, it's 38% at 10 years. So it's 38% of whatever duration that person would have had, it improves survival by 38%. And so I think it is worth taking. And even though the person will not notice a difference from taking it or not taking it, it's generally, for most people, well tolerated. And so if it's going to give you an extra 38% on average improvement in survival, why not take it? Because people are very keen to take all sorts of experimental things that have no evidence whatsoever, no known safety profile, etc. Why not take something that has been through all of that and has a known benefit that can be quantified versus the risk of taking it?
Great. So to come full circle, Chris in his tweet and Bernice in her presentation at the beginning of this webinar both gave their top 5 things they would tell someone who is newly diagnosed with ALS. Bugyeong, what are the top 5 things you would tell someone?
Yeah, I will count 3. 1, take your time. It's fast, but not like cardiac arrest or car accident or sudden inflammation, then you need a quick treatment. You can take your time and talk about it with your family and friends. And I hope to find your own way in your own pace. And we have a team of ALS specialists to support. So first, take your time. Second, visit clinic and ask for help, even though you don't want to visit. It's important to do the symptom management at the right timing, and we are here to find out and help as your disease progresses. So visit the clinic routinely every 3 months, 6 months, or 2 months. And if you have financial problem, please let us know. Then we can connect you to the social worker department or introduce to the right people, right agency, or right someone outside the hospital to connect you for financial help. And also, yeah, you may have a chance to meet nice people at the waiting area. So it's important to visit clinic every now and then. And the last one I want to say is don't fall for scam information that usually in their early diagnosis, it's quite alluring that like someone suffered for ALS for like 20 something years, run, like finally able to run after this treatment and after like this drug. I think it's quite alluring, but it should be careful, and it is likely to take your energy, take your money, or like trust in humanity. So start with formal information with enough scientific background that even though the science cannot answer all of your questions, but can keep you on the right track. So yeah, that's my 3 notes.
Very great tips. Ammar, what are your top 3 to 5 things you would tell someone newly diagnosed?
This is a difficult question, and I agree with Bugyeong's ones. They're very nice ones. Going on from what Bugyeong said about people wanting to take your money or selling you or implying that there are miracle cures out there, I usually point people at the ALS Untangled website, which is run by Richard Bedlack from Duke, which is a very, very well curated list of potential treatments and the evidence for them, how much evidence is there, what's the quality of that evidence, what's the conclusion. And people can go there, and then if they're looking at potential treatments of some kind, they can see what is the evidence for that treatment. Is it worth trying it as an experimental thing? And I think it's a wonderful resource. And it's written, it includes people living with ALS in the panel that reviews the treatments, and it's written in a way that anybody can understand. I always tell people about that website. I tell people about the MND Association in the UK, but people should contact their own association locally, because those are people who have lived experience with ALS, either as a carer or in some other way they're connected with ALS. And so they have many, many resources that are useful for the person, even practical things like, how do I go on holiday? Who pays for the insurance? What kind of travel insurance is there? How do I get financial support from the government? That kind of thing is very useful. I explain that there are things we can do. It's not a hopeless situation. I make it clear that we are all here to support people, and that there's an army of researchers, not just in our clinic, but across the world, trying to find a cure. And it really is an army. It's a gigantic, as you know, from the ALS Association, there is a huge number of people out there trying to find a cure for this condition.
That leads to hope, and that's a wonderful thing. Thank you both so much. So we do have some questions, and we'll take a couple minutes to run through a few of these. The first one is about around mental health. So I'm going to just read it directly. Can you explain if and why an ALS MND patient may actually experience good and bad days? Specifically, it seems that when you do not get a good night's sleep, have life stress, or you are cold, your movement, breathing, and speech may be different. I have experienced some doctors that dismiss this perception, which is indeed reality, and say that it is not actually an ALS symptom and that ALS symptoms are more constant and only decline. It is a confusing and stressful situation for a newly diagnosed patient and family. For example, speech may be better from day to day and at times of day. Walking may be more stiff and bouncy. Choking may be more at risk at night or when tired. So how do you explain those changes, and what support options are there for mental health care? Ammar, would you like to take that first?
Yeah, so I would say it's very common for people to experience fluctuations. And the reason, I think, is also quite clear. Everybody has good and bad days, regardless of whether they have ALS or not. And if you sleep poorly or you're cold, your muscles just won't work as well. If you've got a lot of reserve because you don't have a condition affecting your nerves and muscles, you won't really notice that. But if you've got something that's already making them not function optimally, and then on top of that, you put some stress, you put some tiredness, you put some other kind of challenge, cold weather or whatever, then the muscles won't work as well as they would. And as the day progresses, people get more tired. We see that with other neuromuscular conditions. Myasthenia gravis is the most common where we see that, where it's very dramatic. But actually, we also see it in ALS. So that's why people's symptoms fluctuate day to day. Everybody has good and bad days, but you're more likely to notice it when your muscles are already affected.
Bugyeong, anything to add to that?
So before I go into nursing school, I would ask the questions like this to doctors. But in a medical point of view, there are symptoms that is pathogenic or that need to be clinically treated, or the symptoms just people regularly have. And like Dr. Ammar said, the symptoms fluctuate. They have good and bad days. And sometimes people have respiratory difficulty. They are more keen to their body and their symptoms. And even though they got newly diagnosed ALS, emotionally, they are more focused on their own symptoms. So they may feel small changes may feel bigger than their caregiver sees. So I think it's normal, and you will have better days. And since the spring is coming, usually patients feel slightly better, and the weather is nice, and their muscle is less stiffer than winter time. So I hope it gets better.
That heightened awareness to every little change is definitely something that I think is common for anyone facing a new diagnosis. And also understanding that things sometimes now will take a little longer, and there will be challenges and changing challenges on a regular basis, and embracing the joy of those good days and when things are going well, I think is also really important.
And I also like to mention that if the doctor does not give you answer every time, but it's important to address your questions, your symptoms that you currently feel, so that we can see some signs that needs to be treated. So it's important to tell, and thank you for sharing the experience.
So another question, this is around respiratory care. There's also seems to be reluctance for some doctors to consider or recommend investigation of a diaphragm pacer. It is an option that has and can work very well to permit patients to breathe without full-time ventilation. Are there any tips for people living with ALS to facilitate getting used to using their BiPAP? I think two questions into one there. And Ammar, I'll let you start with that, the diaphragm pacing question, and then getting used to their BiPAP.
Okay, so the diaphragm question, just to explain to people who may not know what a diaphragm pacer is, it's a wire that goes into the muscle of the diaphragm, and because our muscles work by electricity, it provides electricity which makes the muscle contract. But it's not done to time with breathing. So it's not that the muscle contracts and then makes you take a breath in. It is simply stimulating the diaphragm on a regular basis to try and keep the muscle strength up in some way. Clinical trials have been done of diaphragm pacing, and actually one of those in the UK and Europe showed that diaphragm pacing is actually harmful, that people with a diaphragm pacer died more quickly than people without a diaphragm pacer. So we would not usually recommend diaphragm pacing ourselves. So that may be why doctors are reluctant to talk about it. In terms of getting used to BiPAP and non-invasive ventilation in general, that's something that the respiratory team will talk to people about. There's lots of reasons why it might be difficult. For example, non-invasive ventilation, the machine is quite noisy. And if you're using it at night, it's disturbing. And it's also disturbing for your partner. It's blowing air at your face. It's not oxygen. It's putting pressure, increased pressure of air into your face. And so that's also, some people find that uncomfortable, suddenly having air coming into your face. It's quite dry air, so having some kind of moisture in there is useful. So there's lots of reasons why people have difficulty. There's also a mask that fits tightly and might cause pressure sores and those kind of things. So we usually give people a trial of NIV, and then they have some time actually with the appointment when they're first given the machine to make sure that they can tolerate it at least a bit. And then they go home and try it. And then we see how things go from there. And then usually there's a follow-up visit to see if any of the problems are solvable. And most people do tolerate it well. And actually many people find it changes their life. It's transformative, because all those symptoms of poor respiration, like muddied thinking, poor appetite, fatigue, all the things actually Bernice was talking about at the beginning, those all improve with non-invasive ventilation, as Bugyeong also said.
Bugyeong, do you have any additional tips? Nurses always have good tips.
So like Dr. Ammar said, diaphragm pacer has a safety issue, so I'm not used to it, and we have no experience in our clinic, so I'm sorry, I don't have anything to add. And about the NIV, yes, we have patients who cannot sleep with their BiPAP. So in that case, we usually have the patient hospitalized for a couple days and try to set the PEEP, set the pressure, breathing rate, and even change the mask with their nose or their nose cover, full mask for a mask with a strap on their head. So there are different options that we can try. So I think it will be discussed with their doctors in the long run.
Again, I think the theme of relationships and really having that multidisciplinary care team is so important, because talking with your pulmonologist or respiratory therapist about the challenges maybe of adjusting to non-invasive ventilation, they're there to help you problem solve and try 52 different masks if that's what needs to happen, or whatever the case may be. So adjusting pressures and in really helping people understand how to kind of ease into it if they are having problems, I think is an important, again, relationship for people living with ALS to have. Ammar, a question directly to you. Is there any update on the practice parameter, the care of the patient with ALS, report of the quality standards subcommittee of the AAN multidisciplinary team? So is there any update on the practice parameter for the care of the ALS patient?
So the AAN is the American Academy of Neurology. So we don't follow their practice parameter. We have our own, which is the National Institute for Health and Clinical Excellence in the UK. So I'm afraid I don't know the answer to that question. I can find out for you and then let you know. In terms of the NICE guideline, the UK version, that has been updated relatively recently.
And this next question for both of you, do you have any tips on how to organize our day or week with the multidisciplinary team? Do you, and I'm curious, because in the US, it's traditionally, you come for one visit, maybe a half day long visit, 4 hours or so, that you're in the clinic. And so we would work with families to help them understand with where they are in the disease, is it easier to come in the morning or the afternoon? If they're traveling, what arrangements need to be made? But what are your recommendations when you work with families? Ammar, you can go ahead and start.
Okay, so we have, there's two different multidisciplinary teams from our point of view, as I explained at the beginning. So the specialist team, we have a one-stop shop. So when people come to the clinic for their follow-up visits, they also see the therapists at that visit, and they see whoever they might need to. So if they need to see 6 different members of the multidisciplinary team at that visit, they'll see 6 people if they need to. In terms of the community team and organizing that, that's a different thing. We don't get involved in that because that's the community team, but we do help coordinate it. And for those visits, because they're in the patient's home, the person living with ALS can then plan it themselves. And of course, it can be tiring having, and also you can have many people coming into your home. It can be quite an invasion and feel very crowded, as I think Bugyeong said earlier as well. Actually, meeting lots of people is tiring as well, and they may be changing people each time. So generally, it's important to have the therapists you need at the right time. That's the key thing. So physical therapy, occupational therapy to solve those practical problems, speech therapy, dietetic support. Those are the 4 big ones, and of course all the others. But a lot of those can be done in the community. The specialist ones we do as a single visit.
Bugyeong, what about you?
So here, I think it's quite old-fashioned. We have neurologist ALS clinic with neurologist and specialist nurse at the center usually, and we set appointments for the next visit. So we make appointments with, for example, like neurologist at 10 p.m. It may take like 30-40 minutes, and then set another appointment for rehabilitation at 10:40, and that goes on like that. And maybe schedule a Radicava injection when they're in the clinic at like 1 p.m. after lunch. And if they see language therapist, then they make arrangements with the language therapist like at like 3 p.m. on the same day. So we want to have all of the specialists in one place, then patients there and want to meet other people in the same room. Patients does not want to, if the patient like stays there and not move around, that's the best. But like we are in the hospital and we have to follow the hospital system and the national health insurance. Yeah, that's what we do, like old fashioned, make appointments for every like team members.
I agree with your comments about meeting people in the waiting room and how important that can be. I think sometimes I would see when I was working in an ALS clinic, while all of the patients and caregivers were waiting in the waiting room, they were there on the same cadence. So every 3 months, so they'd get to know each other, and it became their own little support group in a way. And I think that that's so important for people who are newly diagnosed to have that opportunity to meet other people that are living with ALS. And I would say that one of my top 5 things would be to meet someone else who is living with ALS and talk with other families who are on this journey and learn from those around you, because in addition to all of the tips that we've shared today, there's great information out there, and the best information comes from those who have gone before on this journey. And so reaching out and having that opportunity to meet other families is important, and the clinic does give that opportunity at times. Well, this has been an amazing conversation. Thank you both for your time and for your expertise and for your passion in caring for people with ALS-MND. You both make a huge difference in a lot of lives, and we really appreciate you. I also would like to invite everyone to register for the second webinar in this series called What Are My Ongoing Needs with ALS-MND? I think this is a really nice series that the International Alliance is putting on, addressing various phases of living with ALS, because needs do change. So I encourage all of you to sign up for that. And I would like to now turn it back to Kathy Cummings for closing us out.
Thank you so much, Leslie. And I mostly want to close us out by saying a huge thank you to Bugyeong Son, to Ammar Al-Chalabi, to Leslie Ryan, and most importantly to Bernice You for sharing her experiences of what was important to her at the time of diagnosis. We really recognize that we've seen the perspectives, fantastic perspectives from geographically from England, from Korea, from the USA in our webinar today, but really there's universal application to everything that was talked about. So many of the themes are important no matter where you live geographically. If you're a person living with ALS or a caregiver, family member, everything that was talked about today is so important. So thank you so much to Bugyeong, Ammar, Bernice, and Leslie for your sharing your thoughts today and sharing your expertise. So very much appreciated. Thank you, everybody.
Thank you.
Thank you.
Thank you.